Good afternoon, everyone. Myself, Dr. Deepa, working in oral pathology department. So today we are going to have a lecture on Cementum. So Cementum, it's, as you all know, it's covering the root surface of the teeth. In this picture, you can see this thin yellow line. It is represented with Cementum. So Cementum is basically providing anchorage to the tooth. So we'll be discussing various physical, chemical properties of Cementum, how Cementum is getting formed, what are the different types of Cementum junctions, various functions of Cementum, various clinical considerations and age changes of Cementum. So I hope after my lecture, you'll be having idea of all these subheadings. So the definition of Cementum is given in 10K Act. It's a hard, avascular connective tissue that covers the root of the teeth. So it is hard and it is avascular. And if you see the tissues of the periodontium means surrounding the tooth. You have two soft tissue, you have two hard tissue. So gingiva and periodontal ligament just comprises the soft tissue component, and cementum and the alveolar bone comprises the hard tissue component. So cementum is one of the component of tissues of periodontium. Okay, as I already told, cementum provides anchorage for the collagen fiber bundles of PDL. And cementum, if you see, it is extending from the cervical portion and it is extending till the apex. And if you look carefully, the thickness of the cementum also varies. It is thin towards the cervical region, and as it comes towards the apical, the thickness increases. Not only the thickness, the type of cementum also varies from the coronal part to the apical region. So we'll be seeing all that in the coming slides. So that was just introductory point. And coming to the discussion on various properties of cementum. Physical property, that is how hard cementum is and what is the color of the cementum. If you see the hardness, its hardness is less than dentine. So if you compare the tooth structure, enamel is the hardest, then dentine, then comes cementum. And even the color, if you see, its color is slightly lighter in color as compared to the dentine. Dentine is little more yellowish in color. And enamel has the translucency, but cementum lacks the translucency of enamel. So I hope if you can differentiate by just looking at the tooth, I hope you will be able to differentiate between enamel, dentine, and cementum. Okay. Similarly, if you compare it with bone, cementum is avascular and non-innervated. Okay, this has got important application, like when you think of the clinical consideration. So we'll be discussing this point also in the coming slide. So just remember, cementum is avascular and non-innervated. So if you just think of the chemical property, that means what all it is comprised of. So it's 45% inorganic and 50 to 55% organic. That is slightly more the organic material percentage. And inorganic portion, it's just hydroxyapatite crystal, just like enamel and dentine. And it has got highest fluoride content of all the mineralized tissue. This is an important MCQ question. So compared to the tooth, enamel, dentine, so cementum has got highest fluoride content. And if you see the organic portion, it is mainly composed of type 1 collagen, and it has got various non-collagenous proteins like osteochondrin, bone, xyloprotein, etc. But the cementum-derived attachment protein, that's a unique protein which is seen exclusively in the cementum. Okay, so this is about, just remember the percentage of this organic, inorganic material. Okay. So coming to the next session, that is cementogenesis, how cementum is getting formed. Okay, let me explain this picture first. So you all know the odontogenesis. This is the advanced bell stage. You can see enamel, you can see dentine. This is the inner enamel epithelium. This is the outer enamel epithelium. So the cervical loop is the place where the inner and outer enamel epithelium meets. Okay, so once the crown portion is complete, the cervical loop further proliferates down and continues as HERS, that is Herdman epithelial root sheath. This HERS has got a major role in the root formation. So in cementum formation also, HERS has got an important role. So just look at this picture carefully. This is again representing the cementogenesis only. So this is the dentinal side, the dental papilla side, and this is the dental follicle or dental sac. Okay, so from the dental papilla side, odontoblast is getting derived and it is laying down the dentine. Okay, so as the HERS comes down, the odontoblast proliferates, odontoblast differentiate gets differentiated from the dental papilla side, and it is getting depositing the dentine. And when there is, then soon there will be degeneration of this HERS, and from the surrounding HERS, from the surrounding dental follicle cell, cementoblast is getting derived, and cementoblast slowly starts depositing the cementum. Okay, so this process continues further towards the apical side, and the cementum is getting formed. So this is just the written matter of whatever I explained now. Cementogenesis preceded by the deposition of dentine on the inner aspect of HERS. First break in the epithelial root sheath, allowing the newly formed dentine, and then come in contact with the connective tissue cell of the dental follicle. And cementoblast derived from the dental follicle is responsible for the cementum formation. So in case of amelogenesis, we know first the odontoblast is getting formed. It is giving signal to the ameloblast, and then ameloblast secretes enamel. Similar way, here also first odontoblast forms root dentine. After that, the cementoblast is getting derived from the dental sac, and then cementum is getting deposited. Okay, so that was all about cementogenesis. And before going to the type of cemental junctions, I want to explain what are the different types of cells you have in cementum. Okay, so cementoblast, just now I told you, it is basically deposited with the cementum, and it is usually seen at the surface and laid on cementum on the root dentine. Okay, and cementocytes are nothing but entrapped cementoblasts that are embedded in the cementum, that are only known as cementocytes. So you have mainly two types of cell in cementum. One is cementoblast, and then next is cementocytes. Okay, so cementocytes have these projections known as canaliculi. Even osteocytes has also got these canaliculi projections, but there's a difference. Osteocytes, the canaliculi projections is multi-directional. That is, it's pointed towards all sides. But if you look carefully, cementocytes, the canalicular projections is unidirectional. In this case, you can see that it is facing towards this side. That is, it is facing towards the periodontal ligament side. From this side, it is getting the nutrition. So it is unidirectional, whereas osteocytes, the canalicular projections are multi-directional. Okay, that question you can get for your Viva. Okay, and next we have come to the next part of the today's class, that is different types of cemental junctions. First, we'll be discussing about cementoenamel junction, then cementodentinal junction. Okay, so cementoenamel junctions, you have this is an important your theory as written as well as Viva. It is very important. So you have three types of junction: overlapping junction, edge to edge junction, gap junction. The most ideal is edge to edge. You must remember the percentages also. Edge to edge, there is only 30%. Overlapping, it's the most predominant type, 60%, and gap junction, it forms only 10%. So there is reason that why you have overlapping junction, why you have gap junction, etc. So why you get overlapping junction is because sometimes you all know after the crown portion is complete, the reduced enamel epithelium is covering the crown. Sometimes when there is early degeneration of this reduced enamel epithelium, okay, cementoblast is getting derived from the dental follicle cell, and cementoblast starts laying down cementum. Similarly, in gap junction, what is happening is sometimes the reduced enamel epithelium, there is delay in the retraction or degeneration of reduced enamel epithelium. So the cementoblast is not able to deposit cementum on this region. So this is a reason why you have overlapping junction, why you have gap type of cementoenamel junction. Okay, come to the next junction, that is cementodentinal junction, junction between cementum and the dentine. So where you can, this side, the brownish shade, that is cementum, and where you can see the tubules, that is the dentinal side. And the cementodentinal junction permanent teeth is smooth. Okay, whereas if you remember, the dentinoenamel junction is scallop, but here cementodentinal junction is impermanent tooth, it is smooth, whereas it is scallop in deciduous teeth. And this picture itself, we can see these lines. These are nothing. These are the incremental lines in cementum, which are known as lines of Salter. It deposits, it indicates the periodic deposition of cement. Okay, so lines of Salter and the difference between cementodentinal junction in permanent teeth as well as in deciduous teeth. Coming to the next, that is hyaline layer or intermediate cementum. Okay, so first I will just explain this picture. This A, that is a cemental side, D, that is a dentinal side, and C, that is a Tomes granular layer. That is nothing That's the granularity, which is seen in the root dentine. And you all can see B here. B is nothing but intermediate cementum. That is a layer between the cementum and the dentine. Why it is known as intermediate or hyaline layer is because it doesn't exhibit the characteristics of either cementum or dentine. It's just a hyaline layer, structureless layer. And it is predominantly seen in the apical two-thirds of the roots of molars and premolars. So hyaline layer of Hopewell's myth or intermediate cementum. This is also important MCQ question. So far we've discussed about the various properties of cementum, how cementum is getting formed, what are the different types of cells you have in cementum, and what are the different types of junctions you have in cementum. Okay, so almost half of the class is over now. Next, we are coming to the types of cementum. Okay, so we can classify it based on two criteria. First is based on the presence or absence of cells in the matrix. That is first I showed you that. Okay, first is acellular cementum or primary cementum. Acellular, as the term says, there are no cells. Next is cellular cementum or secondary cementum. Primary cementum is a first form cementum. Secondary is a later stage and it has cellularity also. And if you classify it based on origin of the collagen fibers, that is intrinsic fiber cementum, which is derived from the cementoblast. That is cementoblast producing fibers are only known as intrinsic fiber. And if it is derived from the PDL, that is extrinsic fiber, that is which is from outside. So based on these two criteria, we are classifying cementum into various types. And Schroeder in 1986 proposed this classification based on cellularity and fibrillarity. Acellular, afibrillar, that means no cells, no fibers. It's mainly seen towards the coronal side of the cementum. And acellular extrinsic fibers, that means no cellularity, but you have periodontal ligament fibers. Next is cellular mixed. It has got cellularity and it has got extrinsic as well as intrinsic fibers. Cellular intrinsic means only the cementoblast derived intrinsic fibers are there and you have cells also. Acellular, intrinsic, no cell, but you have cementoblast derived fibers. So this is a classification based on cellularity and fibrillarity. It is proposed by Schroeder. So when a question like types of cementum is asked, you must write this classification. This is another important question from this chapter, that is difference between acellular and cellular cementum. Okay, so first I'll explain the picture, then we can read the slide one by one. So acellular, you can see in the picture, acellular is more towards the cervical side and cellularity is more towards the apical side. Acellular primary cementum, cellular secondary cementum. Okay. And not only, you can also see the thickness also varies. Acellular thickness is less, cellular thickness is more. Okay. And just see the picture under the acellular cementum. D is the dentinal side, C is the acellular cementum. Similarly, picture under the cellular cementum. D, C is the cellular cementum. So acellular means there are no cementocytes here. Okay. In cellular cementum, you have this entrapped cementocytes here. Its thickness is more, its deposition rate is faster. Okay, the Sharpie fibers, it's not that mineralized, whereas here, in acellular cementum, the cellularity is, there is no cellularity, so Sharpie fibers are more mineralized. Okay, so let us read the point one by one. Acellular cementum, embedded cementocytes are absent, but cellular cementum, cementocytes are present. Deposition rate is slower, but deposition rate is faster here. You can see the width is also more. It's a first form layer, acellular, cellular formed after this acellular cementum. Width is more or less constant, width can be highly variable. Okay, acellular, the location, you know, found more towards cervical third, and it is seen more towards apical third and interradicular area. Another name for acellular is primary cementum, secondary cementum. Here no cellularity, so Sharpie fibers are more mineralized. Here it is partially mineralized. Here incremental lines are regular and closely packed. Here increment, as the deposition rate is faster, incremental lines are placed wider apart and it is more irregular. So whenever this question is asked, you must write in table format and you should not forget to draw this diagram also. Okay, so we have almost reached the end of the session. I hope so far whatever we did was clear. Next, coming to the functions. So it's providing the anchorage. How anchorage? It's providing a medium of attachment for the collagen fiber bundle of PDL to the alveolar bone. It is connecting. Next, functional adaptation. Whenever there is any minor adaptation needs to be done, the cementum helps in adapting. Then repair. Cementum is major reparative tissue for the root surface. So anchorage, functional adaptation, and repair. So that was a various function. Coming to the clinical conservation. The first slide I told, cementum is avascular and non-innervated. That is, cementum is more resistant to resorption than bone. So whenever this orthodontic tooth movement, whenever orthodontic force is applied, it's the bone which is getting resorbed because it has got vascularity. It is the bone which is getting resorbed. Cementum is not resorbing because of this property. Okay. And repair of the resorbed tissue. Whenever there is resorption, either anatomical repair or functional repair. Anatomical repair means when the anatomy is retained, whereas functional means the function is when the defect is more. Sometimes anatomical repair may not be possible. That time, functional repair, that is repair of resorbed cementum. Okay, the last 8 changes. Increased thickness due to passive eruption whenever there is attrition. The cementum gets deposited, the cellular cementum gets deposited the apical side, and when there is hypercementosis, that is what you mean by increased thickness here. And as a person ages, the cellularity, that is increased degeneration of the cementose site. The cellularity reduces. So these are the 2 major 8 changes you have in cementum. These are some of my references. I hope it's clear. Thank you.